Thank you to both Vinny and you, Sybil, for inviting me. I think it's a great honor to be coming here and talking with your group. But my name is Tashina McCluskey, and this presentation will be, as the title slide shows, an overview of artificial intelligence, or AI, in critical care. The tech and research in AI is rapidly evolving to the point that literature from 2021 seemed a bit dated when I reviewed it compared to literature from this year. And I've actually already updated some things in this presentation since I gave it last in September. So always rapidly evolving. There we go. So a little bit about me. I am a clinical nurse educator for a combined medical, surgical, cardiovascular, and neuro ICU at the St. John Regional Hospital in St. John, New Brunswick. So I do a little bit of everything. And we have a little bit of a coast-to-coast, east meets west thing going on here, so I kind of like it. I have been an RN for over 20 years, and as I mentioned, all of it in ER or ICU environments. I am by no means an AI expert, although since doing this presentation, I've been asked to speak on AI in a couple of different places, so that's kind of neat. It's a fake it till you make it happening in real time right now. Another disclaimer, I do talk about a few examples using their brand names. ChatGPT is in the title, but I do not endorse any of these, and I am not being funded by any of them. Some of them I haven't even used, but I found them in my research. I debated using specific named examples in the presentation, but it lost some of the oomph without them, so I kept them in. All right, so here's the list of the questions that I will hopefully be answering in the next 45 minutes or so. First one, what is artificial intelligence? We hear that term a lot nowadays, but what does it mean? Second, where are we using AI in critical care? As you may or may not know, AI is actually being used in critical care environments right now. Third question, what are the challenges? So no new technology comes without challenges, considerations, and limitations. So we'll talk a bit about those. And the fourth question is, how does the future look? What are the things going to look like? As I said, being a nurse for 20 years, I have seen some gigantic changes over my career, and things are only going to get more interesting. So first and foremost, I want you guys to take a moment and have you think about what the term artificial intelligence means to you. So I did a random poll of some people around me, and most of them thought of things like aliens and robots, sci-fi books, movies, TV shows. Skynet from Terminator was a very, very big one. Some other people were able to come up with things like ChatGPT and Siri. So getting out of the realm of make-believe and into things that exist right now. The term artificial intelligence, or AI, has actually been around since around 1956. Over the years, the definition has changed, and there's always some debate on what a good definition is, but I do like this one from Encyclopedia Britannica. So, artificial intelligence is the ability of a digital computer or a computer-controlled robot to perform tasks commonly associated with intelligent beings. So there's a few things to unpack with this definition. One, AI is a computer program. It can control something physical, like a robot, but it of itself is digital. Second, that program can perform tasks that usually only intelligent beings can do. These are things like reasoning, generalizing, learning, problem solving, adapting to changes. Computer programs can be very smart and very, very complex, but they are built by following specific algorithms and instructions programmed by humans. If this happens, I do this, etc. AI programs have programming, but they also learn from past experiences and use that knowledge in future situations. For an example, a smart thermostat can be programmed with a clock to know that the heat needs to go up this time and go down at this time. A motion sensor might be involved that can detect when people are in the room and adjust the temperature accordingly. It switches to energy saving mode when the room is empty, stuff like that. So it's smart, but not intelligent. It's all in its programming. An AI thermostat could potentially learn Oh, my people usually get off work a bit later on Thursdays. So I should probably start warming up the house a little bit later just to preserve energy in that. Bob usually likes things cooler than Sally, and I can see that it's Bob in the room, not Sally. Oh, but Bob's wearing a sweater today, so it probably means he's cold, so I'm going to adjust the temperature up a little bit more. So learning and adapting without being specifically programmed to do these things. One last thing before I switch the slide. There are some who would argue that a true AI doesn't exist yet, because how do we know that the program is learning and applying what it learns because of intelligence and not just very, very in-depth programming? As a counter argument, how do I know my 3-year-old has learned her ABCs and isn't just programmed to respond a certain way when she sees a certain image? That's an imperfect example, but I throw it out there just to illustrate that there's a bit of philosophical debate that comes with definitions like this. From philosophical diversions like that comes the Turing test. The Turing test, also known as the imitation game, was created in the 1950s by Alan Turing, an English mathematician and computer scientist. There's a movie about him. It was released in 2014. How the Turing test works is that an evaluator asks questions to two entities in different rooms. It doesn't know what's what. One is a human, one is a computer program. The evaluator then tries to determine which one is which based on the answers. The computer program passes if the evaluator can't distinguish it from the human. It just shows how well AI can imitate human behavior. Not necessarily that it's intelligent, just that it is able to answer questions in a human way. ChatGPT, which will come up a few times in this presentation, again, it is in the title, was tested by Stanford researchers in February of this year, and they published their results stating that it had passed a rigorous Turing test. The only way it diverged from human behavior was that it was actually nicer, as in more altruistic and cooperative than what we expected from an actual human. To continue on this theme, on December 22nd and 23rd of 2022, a cross-sectional study was performed to evaluate the ability of an AI, again ChatGPT, to provide quality and empathetic responses to patient questions. These questions were pulled directly from a public social media forum, Reddit's Ask Docs, where the answer received was from a verified physician and then asked to an AI, again ChatGPT. So, evaluators took both answers and judged them both on the quality of the information given and the empathy or bedside manner provided. In 78.6% of the cases, the evaluators preferred ChatGPT over the physician, both in quality of information and empathy. Before we get into the meat of the presentation, AI in critical care, I do want to take a quick sidestep into some terminology, starting with two classifications of AI that exist today: predictive AI and generative AI. Both predictive and generative AI take data, analyze it, and apply sophisticated algorithms to produce an end result. What that new content is what separates them. So predictive AI uses the data it is given to make predictions, kind of self-explanatory. Everyday examples include the AI that Amazon uses to make recommendations based on your searching and buying habits, and the AI Netflix uses to make their movie recommendations. Generative AI, on the other hand, learns patterns of existing data and uses those patterns to create new content. An example of this includes ChatGPT and Midjourney, which are generative AIs that can create text or graphics based on the prompts you give them. A large amount of the pictures in this presentation were created when I typed some variation of the prompt, "Give me an image of artificial intelligence in critical care," into Microsoft Designer, which is another Gen AI. As a healthcare example between these two, predictive AI can analyze patient data and predict the risk of cardiac arrest. Generative AI can take that same data and generate a treatment plan to prevent the patient from going into cardiac arrest. So kind of a little bit of an interesting difference there. The level that an AI can exist on is on a spectrum. So a narrow AI is good at the specific tasks in which it's been taught to perform. A general AI would function as humans do, so being able to perform multiple tasks in multiple different areas and learn from those experiences and apply them to other tasks. This would be like your androids and everything like that. This type of AI doesn't really exist yet. And then a final bit for some terminology. When you hear about AI, sometimes you will hear the term machine learning. What this refers to is a technique in which the AI will take the data, apply the algorithms, and select features programmed into it to give the result. What makes machine learning different from other computer programming is that the computers are making the decisions on their own. A human might not even oversee the process at all after the initial programming. And once it starts going, it might progress to the point that the human programmers might not even understand how or what it's learning. Sometimes AI and machine learning are used interchangeably, but one is the thing and the other one is how the thing does the thing, if that makes sense. Now that all that is out of the way, where are we using AI in critical care right now? As of August 7th, the US Food and Drug Administration, the FDA, have authorized 950 different AI/machine learning enabled medical devices. So that's a gigantic number. This list is not specific to critical care. They do list all their approvals based on specialities. Critical care isn't separated as one on its own. Radiology is a big one, followed by cardiovascular, and as we can all guess, advancement in these areas can also apply to critical care environments. Much of this stuff is still in its infancy, and a lot of the really interesting stuff exists in a more theoretical and research zones instead of direct clinical. But we'll talk a bit about how it's growing and evolving. A couple of caveats to these numbers. Just because something is FDA approved doesn't mean that it's being used. Just because it's being approved doesn't even mean it will be useful from a clinical perspective. And just because something isn't approved doesn't mean it isn't being worked on. So these numbers can be skewed a little bit. First off, before I move on, I want to show some love for this picture over here. So this is me. This is generated by Gen AI. And I am just trying to do a good physical assessment of my first day in an ICU. And this over here, this is my AI preceptor. They are not very amused right now. They're wondering when I'll realize that I'm listening to lung sounds with my name badge and not my stethoscope, which is still on my neck. And also that I'm assessing a mannequin and not my actual patient. AI is not always perfect with this stuff. Anyway, sorry. So here's an exciting statement. ICU is one of the top spots for artificial intelligence in healthcare. We have a large amount of data from our monitoring devices, and it's being collected either continuously or near to it. Respiratory assessments, hemodynamic data, neurological, emotional status, blood work, imagings, et cetera, et cetera, et cetera. We perform multiple interventions and can see those changes in real time. And then we document the responses to those interventions. AI loves data and can analyze large amounts of it quickly. We have data and we like things to be quick, so it is perfect. Some of the things that AI can do with that data is to help us with early detection and diagnosis of conditions and diseases. It can help predict the progress of those diseases and highlight risks of our patients deteriorating. It can help us manage our interventions by aiding in our decision-making, and it can give us more time with our patients by making our workflow more efficient. Basically, AI can take what we're already doing and help us do it better. This is another fun picture to look at. I asked MS Designer what it thinks a chest x-ray looks like, and it gave me this. I have no idea what this big lump is here, and I don't think that this is a very good thing in here. Anyway, as we all know, with critical care patients, it is crucial to have timely and accurate decision-making. The sooner we have a cause for a problem, the sooner we can get to work to try and fix it. If we work under the assumption that X is happening, but really it's Y, that might at best lead to delays in care or at worst harm for the patient. That being said, finding underlying causes of diseases can be challenging. The early stages of some diseases can be really insidious. Depending on comorbidities or distracting issues, it can be hard to get to the root of the problem. Or maybe there are multiple things going on, and if we narrow our focus too much, we'll miss the other moving parts. AI programs can sift through medical images, laboratory results, patient histories, etc., far more precisely and quickly than humans. Plus, they are really good at pattern recognition, even if it's a subtle pattern. One of the areas in the research is early sepsis detection. One AI algorithm could detect sepsis up to 4 hours in advance. Another one could predict it up to 2 days in advance. Another AI algorithm could predict acute kidney injuries up to 48 hours in advance. Depending on the accuracy of these models, can you imagine how that early intervention could help our patients? The next thing that AI can help with is predicting the patient that may or has already begun to deteriorate. AI predictive indexes already exist for several clinical conditions such as hypotension, respiratory failure, and cardiac arrest. One study showed that AI monitoring and alerts used in the OR resulted in a 1.2% incidence of intraoperative hypotension. That's compared to the 21.5% incidence using conventional methods. So that is a huge improvement. Another study mentioned a model that could predict cardiorespiratory instability, so stuff like tachycardia, hypoxia, respiratory distress, up to 90 minutes before it occurred in real life. Another one reviewed that could predict respiratory failure or cardiac arrest up to 6 hours prior to onset. So lots of time to try to fix the problem. And it can work in the other way too. Instead of deterioration, AI can help monitors for improvement as well. There is an AI system that can help predict the optimal time for weaning patients from ventilator support, leading to less reintubations, less time on ventilators. Which leads us to the next slide, aiding in decision making. As we all know, one-size-fits-all solutions do not work well for complex problems like those encountered when dealing with critically ill patients. AI models can assist in creating personalized treatment plans that are tailored for specific patients based on things like genetic information, lifestyle, medication history, analyzing responses to interventions already performed, etc. There was a study that talked about a hypotensive patient that the AI recommended less fluid and more vasopressors than the clinician. And the AI suggestions with these patients actually did better than the clinician ones. Another AI model could determine an individualized therapeutic dose of erythropoietin stimulating agent therapy for managing anemia in chronic kidney failure patients, which actually was shown to decrease hemoglobin fluctuations, therefore less costs, less frequency of transfusions, less hospitalizations, and cardiovascular events in these patients. Besides recommending treatment regimes, AI can also help predicting the best timing of interventions. One example showed an AI model for electrolyte replacement. By using the patient's vital signs, lab data, drug administration records, and things like that, the AI algorithm could suggest not only which electrolytes need replacing, but also which order, the best route, and dosages for each individual patient. I've certainly had the patient who has had limited IV access that required multiple electrolytes replaced, plus antibiotics and other intermittent medications, and tried to juggle which one's going to go first. If I had this AI program, I could be just like, think for me a little bit, validate what I want to do. Other things like pain management, heart failure treatment, nutritional support, these are all areas that are being worked on with AI right now. Things like this could be especially useful in areas where there's not many experts in critical care, but a patient transfer isn't possible. So like remote areas or resource limited areas, therefore limited treatment options. By having an AI to help guide decisions, it can increase the confidence that these providers that they're doing the right thing with what they have. And the final thing I want to talk about in this section is the effects that AI can have on optimizing workflow. AI can help healthcare professionals communicate more effectively with each other and patients by using AI-powered scribes to write reports and share information. It can assess patient numbers and acuity and help adjust with staffing ratios. It can help with education and training. When I asked for a futuristic ICU picture. And this image here was given of the nurse in a control room with multiple different patients that they're monitoring. I was like, oh, what is that? But this is actually happening right now. There is a device, it's called the Bio Button, and it's a wearable device that can measure vital signs and other things like body positioning and transmit them in real time to a monitoring station. It's Houston Methodist Hospital that is using this right now. A nurse would sit in a control room and monitor 400 plus patients. If the bio button alerted that the patient had a change, the nurse would be able to quickly review the health record to see if there was a reason for it, or call the floor to get the nurses to go and check on the patient. So things like, oh, their vital signs have changed. Oh, well, they just got beta lock. Of course, their heart rate's going to go down. Oh, they've gotten out of bed. Oh, but they're being discharged. Yeah, okay, that's fine. Oh, but this person, their respiratory rate's going down. You should go check on them. Stuff like that. The idea is that now patients will have a second set of eyes on them, so it will improve their outcomes. Plus, it helps reduce the workload of the floor nurses because now they no longer need to frequently monitor vital signs, and they also have a second set of eyes on their patient. So, is something like this more efficient? Yes. Apparently, staff and patients really like it. Does this whole idea here give me a little bit of a chilly feeling in my gut? Also, yes, but I'm getting ahead of myself a little bit there. All right, so now we're going to have some examples of AI. First up is in the title of this presentation, and I've mentioned a few times before, and that is ChatGPT. ChatGPT is a large language model AI, which means that it's trained on the large amounts of text data to understand and respond to text like human conversation. It can answer questions and provide information on a wide range of topics. It literally looks like you're texting back and forth with a super smart friend. It's not specific to critical care or even healthcare, but it can be used for healthcare related tasks. The internal database that it's trained on, at least the version I use, contains data up to September 2021. It can browse the internet for more up-to-date information, although it's limited to what is publicly accessible. It can't access things between institutional passwords or paywalls. Recently, it has been upgraded, so it can do images as well. As an educator, I have used ChatGPT to help me develop lesson plans, generate simulation scenarios like this example here, where I just basically said, can you give me a summary of a patient that was admitted to ICU following a cardiac arrest? And it spits out all of this fun stuff here. And it also can help me brainstorm ideas. The idea for this presentation actually came up by me asking ChatGPT, hey, can you give me a presentation idea for a critical care nursing conference? And it asked me, well, how about doing one on AI? And I said, that's pretty biased, ChatGPT, but I like it. It sounds good. Clinically, ChatGPT can generate potential differential diagnoses and treatment plans. One study found that using it to review journal entries can help detect worsening anxiety, depression, and suicidal thoughts in primary care patients with mental health problems. Another study used ChatGPT to analyze speech patterns and look for things like repeating words, phrases, unfinished thoughts, and vague words. And it was actually able to help identify Alzheimer's patients with about an 80% accuracy just by analyzing those speech patterns. It can also be used to rewrite medical information in a language that the general public can understand. So this is part of the script that I asked ChatGPT to generate based on my fake cardiac arrest patient on how to talk to a family. Remember at the beginning of the presentation when I said people preferred ChatGPT's bedside manner to real physicians? It does a good job of giving you a nice script to at least kind of go off of. You can ask anything you might want to ask a colleague or look up on the internet in ChatGPT, and you'll get a pretty decent answer, especially if you already know enough about the topic to catch any potential errors. In the research, ChatGPT is used so frequently because it's so accessible. It's an app download or a web program, and it's free unless you want all the bells and whistles. All right, next up is Glass.Health. I have not used this one myself, but it looks like something I'd love to play around with. As per the website, Glass.health is an AI-powered clinical decision support tool that works by combining a large language model and evidence-based, peer-reviewed clinical practice guidelines that were created and maintained by a group of physicians. It can give differential diagnoses. We got them right here. As well as, clinical plans and everything like that. So basically, it is like ChatGPT with the bonus of being trained with actual clinical practice guidelines. I've heard of medical residents using this one, and I can certainly see how it would be very beneficial to any new or less experienced critical care physician or advanced care nurse. All right, so this is the next one. I think it's Mutio. I don't know what it is. Autoscribe, anyway. What Autoscribe is an example of a generative AI ambient listen tool for clinical note-taking. What it does is it listens to the conversation the healthcare provider and the patient are having and transcribes a clinical note based on what it hears. It maintains a strict transcript of what it hears, so the information is verifiable. Plus, it can provide summaries to the patient. So the transcript is here, it's listening to that, and it's transcribing. It makes up a note, which you can review, and then provides a patient handout based on what it has found. Autoscribe can be integrated with lots of different EMRs, like PS Suite, Oscar EMR, Cerner, and Epic, where the 4 were listed on its website. And the website itself says that more are coming. Plus, it's made and managed in Canada and trained on Canadian data, which is a nice thing. Horizon Health Network, which is the healthcare authority that I work for, is actually trialing Autoscribe in one of our facilities in Fredericton, New Brunswick. They hope to roll it out to all urgent care and emergency departments in the region. I haven't used it myself, but I do know of several physicians who use medical scribes like this one, and they love it. It eliminates the need to type up clinical and consult notes and allows them to prioritize the patient and the conversation. This is one I think I want Santa to bring me for Christmas. This is the Echo Core 500 stethoscope. The stethoscope itself is not an AI. It is a stethoscope that is built with 3-lead ECG technology. So you put it on the patient's chest and it's able to get the 3 leads by the 3 electrodes, 1, 2, 3 here. Where the AI part comes in is you combine it with the Echo Plus app, which has AI tech that can identify things like AFib and murmurs. There was a small study, it was only 368 patients, but it compared the AI tools built in the stethoscope to detect valvular heart disease, and it could detect it 94.1% of the time versus a primary care physician who could only do it 41.2% of the time. Something like this could be super helpful in the detection of structural heart diseases, and the tech is only going to get better as more time passes. And this is the last one of the specific examples, and this is one that I actually do use. On the Edwards Life Sciences Hemisphere monitor, there is an Acumen sensor that can be connected, and it has the ability to monitor the patient's advanced hemodynamic parameters. It basically sets up like an art line and plugs into the hemisphere. One of the things that it can give us is it can calculate the hypotensive predictive index, or HPI, which, as the name implies, predicts if the patient is going to have a hypotensive event. It grades it on a scale from 0 to 100. The closer you get to 100, the more likely there will be an event where the MAP falls below 65 for at least a minute. An HPI of 86 means there's an 89.9% chance your patient will be hypotensive in the next 5 minutes. By clicking on this more information button, it'll give you this screen. It'll give you those parameters and in a stepwise fashion. So you got your preload, your contractility, and your afterload here. So you can actually hopefully intervene so that hypotensive event doesn't happen. Back when I was talking about predictive indexes, I forgot to mention that they're not always so great. Here's one example where they're not so great. So I was down in my ICU and I stopped by a sick patient's bedside to see if the nurse needed a hand. It was right when we first started using the Acumen sensors and the HPI, so staff still weren't 100% familiar with everything. The staff member asked me, "What is HPI and why does this thing over here keep alarming?" So I explained to this patient, or this nurse, sorry, that it's a hypotensive predictive index. The alarm means the patient's at a risk of a hypotensive event, basically everything that I just told you. And she is looking at me and she was like, "Oh, okay, sure, fine." Now, as I said, this patient was sick. He was a post-op cardiac surgery patient who was on VA ECMO, multiple pressors, milrinone, maybe dobutamine too. I can't remember, it's been a little bit. Basically just IV pumps all running and beeping everywhere. This nurse was literally in the middle of spiking her third bottle of 5% albumin of the shift, and it was probably only like 2 hours into the shift. So she looks at me. She looks at the patient. She looks at all the IV pumps going, looks at the ECMO, and looks at the monitor, which shows the pressure of 70 despite all of this going on. And she says, "Hypotension." No shit. What are the challenges of using AI in critical care environments? The challenge of that last scenario was the AI was there. It was doing what it needed to do. It just was not in any way useful for the scenario. It's not to dunk on the HPI. In some scenarios, it's great, just not that one. Some of the challenges associated with AI include those found during development. So is this needed? Is it safe? Ones found during implementation. So how are we going to build this into our existing infrastructure? And how are we going to train people? And finally, ongoing monitoring. Is this doing what we need it to do? To meet some of those challenges, AI needs to be usable and explainable. It needs to be free of bias. It needs to be accountable, and it needs to be sustainable. For an AI to be usable, it needs to be able to give us things we actually need when we need it. A predictive AI that tells us if the patient is a dog person versus a cat person is neat, but not useful in critical care. Telling us this patient is trending towards a hypotensive event, more useful. Telling us a patient is at risk for hypotension when they're already hypotensive and being treated, not useful. The AI also needs to present that information in a way that can be understood. Giving us a string of 4-point font programming formulas constantly scrolling by, not useful. Green means go, red means stop. More useful, maybe, depending on the situation. Clearly labeled information and a strong indication of what it means for us is much, much, much more useful. AI also needs to be explainable. We need to know how it works within our own personal capacity and where it's getting that information from. Because one of the features of AI is that it can learn and teach itself. Sometimes the rationale of how it comes to its decisions can be complex to outright unknown. A lot of what we do in critical care is based on evidence from things like clinical trials, but with AI, we might not get that. This can lead to a lack of trust and doubting the reliability of the output. It only makes sense that clinical AI should be treated with the same scrutiny as drugs and medical devices that undergo clinical trials. They need to be auditable once they are implemented so we can continue to monitor them. In order to properly train an AI needs data to learn from. And while we like to think that almost everyone that enters our healthcare system is treated equitably, I think most of us would agree that this isn't always the case. How patients are assessed, treated, and charted on can reflect those disparities. If that bias, intentional or not, are used to train an AI, then the AI may then perpetuate those biases and affect the quality of care patients receive. Predictive AI is especially vulnerable when data is limited, biased, or incomplete. Training the AI with a diverse range of standardized data might reduce the risk, but standardization is difficult. Plus, there's a possibility it could make the algorithm too generic and therefore useless. ICU patients have a wide range of ages, genders, ethnicities, cultures, comorbidities, etc. And what works for one group may not work for another. The solution is to have a massive data set that the AI can search through to find information for each patient. However, that requires a lot of processing power, which equals additional expensive. Finally, I did mention that predictive AI is vulnerable to data bias. Well, generative AI can actually create bias, misinformation, or hallucinations, which are AI-created fabrications. One example given in the research was that ChatGPT was being used to produce clinical documentation and present intervention plans for complex patient scenarios. When it was reviewed, it was found that it actually invented physical exam and patient history findings that supported its diagnosis and deleted other ones that went against it. So can you imagine? So, hey, ChatGPT, can you tell me what's wrong with this patient? Oh, I think it's DKA. Well, no, because diabetic ketoacidosis means there's ketones and acidosis, and this patient doesn't have either. Yeah, they do. What do you mean? It's right there. It's right there. What? No, it doesn't. All right, so this is a rough illustration of the bias that can be presented in AI systems. This is a collage of images generated by Microsoft Designer using the prompt, a photorealistic portrait of a nurse looking at the camera. Even though the prompt does not specify gender, it took about 30 tries to get this guy here, a non-feminine image. After about 100 tries, he was still the only dude. After about 100 images, not one image showed a nurse that was not in this ambiguous 20 to 30-year-old range. So I don't know about you, but if I took 30 random nurses working in my unit or my hospital, this is not what a collage of them would look like. The next challenge AI needs to overcome when being implemented in critical care is that it needs to be accountable. If something goes wrong, there needs to be a clear system in place on how it's going to be fixed. Is it the developers who made the AI, the company that marketed it, the organization that uses it, the physician who gives the orders, the nurse who uses the data to implement the orders, the AI itself? Where does that responsibility lie? So if an AI generates incorrect data and the patient is or isn't treated based on that data and suffers harm because of it, who is accountable? If an area is using an AI that predicts an accurate outcome, but it can't be acted on due to lack of resources, who is accountable? If an AI is trained on thousands of patients' healthcare data, and then that data is breached and leaked, who is accountable? AI needs to provide safe, accurate data the healthcare professionals know they can trust. AI should never undermine human decision-making. It needs to assist what we do, not take over. It still needs to abide by the principles of privacy and confidentiality as it pertains to data collection and data safety. This is an article that was in the Journal of American Medical Association in 2021. In this article, the accuracy of a widely used proprietary sepsis prediction model was reviewed using data from 27,697 patients, so a large number, who were admitted to the Michigan Medical between December 2018 and October 2019. What it found was that the AI model performed substantially worse than what the developer had promised. As highlighted here on our screen, it's widespread adoption because hundreds of US hospitals were using this thing at this time, despite poor performance, raises fundamental concerns about sepsis management on a national level, not to mention the use of AI in critical care environments. Another study was published in February of 2024, and it looked at this sepsis prediction model using patients admitted between 2018 and 2020 that expanded a bit on this previous one. What this study found was that the AI could, over the entire course of the patient's hospital stay, correctly predict the high-risk patient 87% of the time. So that's good. However, that number dropped to 62% by the time when the data was only restricted to data recorded before the criteria for sepsis was met. And then that number dropped further to 53% when the data was restricted to before a blood culture was ordered. So it was really, really good at predicting sepsis. when the human clinicians already suspected sepsis and begun investigations. So not so great, and it kind of takes the shine off a predictive model. As one news release stated after the initial JAMA article was released, it wasn't subject to an FDA review process or third-party testing before its initial release. No independent systems were put in place to monitor the use across hospitals or report problems, and its benefits and side effects were not measured in a randomized controlled trial before it was plugged in facilities around the country. This particular case was mentioned as a precautionary tale in many of the articles I read about the challenges of implementing AI system. It was something that, on the surface, sounded great. Who doesn't want an early sepsis prediction system? We all know that as sepsis progresses, so does the risk of increasing organ failure and death for our patients. Predicting the high-risk patients, start treating them early, or at least monitor them more closely, sounds great. Except it really didn't work out that way in this case. Finally, AI needs to be sustainable. It needs to be able to respond and adapt to changing healthcare needs. If we are going to go to the trouble of buying the tech, implementing the tech, training all of the staff to use the tech, informing the public what the tech does, et cetera, et cetera, et cetera, et cetera, then the tech better not be outdated in 6 months. There needs to be a plan. It also needs to be environmentally stable, decreasing the ecological footprint and increasing energy efficiency. I couldn't find an exact source, but there are some comments going around that say that one search inquiry in ChatGPT consumes up to 5 to 10% times the amount of energy that a traditional search engine would. Now that many search engines are using AI, I'm sure that number is narrowing a little bit. And then finally, AI needs to be socially sustainable. Things like job loss due to AI replacement needs to be accounted for. How does the future look? Short answer, either exciting or really terrifying, or most likely a combination of both. One important thing to keep in mind is that critical care medicine and nursing has always been on the forefront of technological advancement. The ventilator, at least as we know it, has only been around since the 1960s. Propofol was synthesized in 1970, but only approved for use by the FDA in 1989. These are things that are used every day in our units that are still relatively young in terms of development. AI is a new tech, and one thing was clear in all the research I did for this presentation: AI is here to stay and will only improve as time passes. The way AI can help with detecting and diagnosing conditions will only improve. It will help improve patient outcomes by predicting deterioration and offering specific treatment plans based on individual patient presentations. It will enhance the way we work by automating the things that can be automated so we can spend more time with our patients. The ways that we, as a global community, can help support this are by doing things like getting more data to increase the reliability of AI outputs and the standardization of data so the AI can use it. Find AI that maximizes the benefits to our patients and minimizes the risks. Support more studies to bring things from research and theoretical into real-world scenarios. Personally, I think the most interesting part of the future of AI is when it gets to the point that the algorithms are so solid that they can start being built into other hardware like robots and really start getting into the sci-fi realm of things. We already have robot-assisted surgical procedures. Imagine a complex AI and a robot and the surgeon working together and how that could potentially improve patient recovery. Some areas of the US are already trialing sending drones to remote emergency scenes ahead of EMS because they can get there faster. Imagine if that drone was arriving with something like Narcan or an AED, and it was programmed by an AI that could tell people on the scene how to use it. This stuff is already in the works, and it's amazing. REFIT, or resuscitation based on functional hemodynamic monitoring, that's what it stands for. It's an autonomous algorithm connected to minimally invasive arterial monitoring and several pumps. So how it works in this experiment that the study was doing is it would monitor the MAP, heart rate, PPV, SVV, and iodine of a patient with a liver laceration going into hemorrhagic shock. By monitoring these vital signs, it could adjust infusion rates to deliver either whole blood, Ringer's lactate boluses, or norepinephrine to try to maintain a MAP greater than 60. It worked well enough to both stabilize the patient and maintain that stabilization during ground to air transport for up to 3 hours. 3 hours was chosen as a time because that would be the amount of time they predicted to get somebody from a remote area to a hospital where they could actually perform the surgical repair. Benefits of something like this could be huge. It was able to minimize both the fluid and medication administration based on reactivity specific to the patient. It didn't require any special critical care knowledge to run. It isn't specific to devices, so as long as you had a standard arterial line inserted that could monitor the parameters and the medication and a device to give them, it would work with the algorithm. Unsurprisingly, the US Department of Defense helped fund this research. There's still a lot of work to be done, but something like this could be a game changer in field medicine or critical care in remote areas. It could also be something that may have a role in trauma care, even in well-resourced areas. If a nurse no longer has to work the pumps, that frees an extra set of hands up, and we can almost always use an extra set of hands. As a final thought for this section, I came across this quote from Stephen Hawking. Our future is a race between the growing power of technology and the wisdom with which we use it. I tried to walk the line in this presentation about being an AI cheerleader and a realist that recognizes the potential pitfalls. I didn't even touch on a lot of the ethical considerations of AI in healthcare, and trust me, there's enough of them to do a whole new presentation on it. Stuff like this is potentially scary, but if we keep that wisdom in the face of advancing technology, if we remember that there is a human patient underneath all that tech that we are trying to do right by, ultimately that should be our goal. It should always be our goal. So it's hard to beat Stephen Hawking as a closing statement, but I'm going to try. I asked ChatGPT, hey, ChatGPT, do you have any final words you would like to say to a group of critical care nurses? I'm sorry if we aren't all nurses. Healthcare providers probably would have been better, who just listened to a presentation about AI and critical care. And ChatGPT responded, as an AI, I would like to say it's been a privilege to share how technology like me can assist you in critical care. Your work is vital, and while AI can provide valuable support, it's your expertise and compassion that make the real difference. My goal is to be a reliable tool in your hands, helping you make more informed decisions and easing your workload so you can focus on what you do best, caring for patients. Thank you for embracing innovation and for all that you do, which I thought was quite nice. And that's my presentation. Thank you.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.